Hello everyone, welcome back to another session in dentistry and more. Today we have very important topic from Endodontics, that is root repair material. So very frequently asked question from this chapter is retrograde material, retrograde filling materials or MTA. MTA is very frequently asked question, so never miss MTA. So we have various types of materials such as MTA, Biodentine, GIC based material, amalgam, Gutta-percha, zinc oxide, eugenol, composites, Diaket, bioceramic, sealers and resin materials. So it is not actually sealants, it is a material. Sometimes it is also used as sealants and also a root repairing material or retrograde filling material or regenerative material. So every material has got many purposes. So to begin with, these roots, they need repair and there are serious complications in dental practice. Sometimes we might face a condition where the roots are injured. Commonly the crowns are getting injured, but sometimes the roots are getting injured and it poses a number of diagnostic and management problems. So when teeth are of strategic importance, root repair is clearly indicated. So with 3D imaging technique and illumination nowadays, the scope and success of this root repair is very high. So the common root repair materials are either root end filling materials after a periapical surgery or perforation repair. It might be an accidental perforation or due to any other reason, and root regeneration material, that could be a biological material or bioactive material. So root end filling material, they are amalgam, Gutta-percha, zinc oxide, eugenol, GIC related materials, composite resins, Diaket, MTA, Biodentine. And this is a question which was asked in one of the question paper, that is a resin materials. What are the resin? Retrograde material or root end filling material. That is ERRM, endosequence BCRRM, bio aggregate, iRoot BP plus and novel root end filling material. So we are going to learn one by one. We'll start with amalgam. Before that we have the next classification, perforation repair material, that is MTA, Biodentine, GAC, well there in root and filling material also, so it has got both functions. PRF is separate, that can do repair of a perforation, whereas root regeneration material, that which has the potential to regenerate the lost tissues. It includes calcium hydroxide. MTA and Biodentine are present in all the categories, that is perforation and root end filling, whereas a root regeneration material has PRP or PRF, those are plasma rich protein. So we'll start with amalgam. It is the first choice of root end filling. The biocompatibility of amalgam is cited as a current issue of concern in dentistry because it was the first material, the pioneer material. Now we have better options than amalgam. So many studies have reported that unfavorable tissue response to amalgam because it is going to be in contact with tissues. Usually we place amalgam within the hard tissues, that is within the tooth, within the enamel dentine, but this is going to be in contact with the soft tissues, so there are high chances of tissue response with respect to amalgam. So the use of amalgam as a root end filling material can now be confined to history, that is it's obsolete material which is no longer be used. The second one is a Gutta-percha, which is a commonly used obturating material, so it is also can be used as a root end filling material because it absorbs moisture from periapical tissues because of its porous nature. Initially it expands, but after it contracts in size and very little inflammation it reported. The third one, that is zinc oxide eugenol cement. So this material was considered to have good handling properties and post-operative results. So we are talking about root end filling material. Okay, root end filling material. So this original zinc oxide eugenol cement were weak and likely to be absorbed over a period of time. So it cannot be kept as a permanent material at the root end or a root filling material. Therefore, it is unsuitable for long-term use. So basically, two approaches were adopted to overcome this problem. That is to improve the physical properties of zinc oxide cement. The first one is a substitution of eugenol liquid with EBA. So EBA and the addition of fused quartz or aluminum oxide to the powder. So eugenol liquid with EBA, that is a liquid part, and the aluminum oxide to the powder part. So it gives rise to the super EBA cement. Okay. Also, the polymeric substance to the powder, such as polymethacrylate to the powder, it is IRM, which is commonly known as intermediate restorative material. So super EBA and IRM are basically zinc oxide eugenol products, but it is modified. It has improved its physical properties, so it can be used as a root end filling material. So that was powder to this polymethyl methacrylate to the powder and polystyrene to the liquid, which is known as calcinol. So all are brand names in display. So eugenol is a major cytotoxic component of zinc oxide eugenol cement, and the zinc released from the cement is considered to be partly responsible for the cytotoxic effect. Now we have the GIC, glass ionomer cement. It is suggested as an alternative root end filling material, but the evidence suggested that there is a cytotoxicity with freshly prepared sample, but it decreases over period. So this toxicity decreases as the setting occurs. Next we have the composite resins and other hybrids. So this biocompatibility of composite resin is influenced by amount and nature of its leachable components. Okay, so the healing of this periradicular tissues to composite is to be very diverse, which ranging from poor to good depending upon the type of material. So we just cannot rely on this composite. So basically the two materials are used, that is Retroplast and Jerry-Store, as a root end filling material. So we know composites being used as a filling material, but this is talking about the root end filling material. Now the Diaket we have learned in the previous session, that was a root the canal sealers. So this is also can be used as a root end filling material. So this is a polyvinyl resin has been advocated as a root end filling material. So when it was used as a root canal sealer, biocompatibility studies show that it was cytotoxic in cell culture, and there is a chronic inflammation in osseous and subcutaneous tissues. But when it is mixed at a thicker consistency, it can be used as a root end filling material. In that consistency, it has shown good biocompatibility with osseous tissues. Now the most important one, that is a mineral trioxide aggregate or MTA. So MTA was first described by Lee and Mahmoud Rabinejad in 1993 as a root end filling material. So it is very biocompatible with numerous exciting clinical applications in endodontics. So this material appears to be an improvement over other materials that involves root repair and bone healing. So this is a composition. It has got powder and water, distilled water in the water segment, then tricalcium, dicalcium silicate, tricalcium aluminate, tetracalcium aluminum ferrite, calcium sulfate and bismuth oxide. So availability of MTA. This MTA is a fine hydrophilic powder available in single use sachet of 1 gram, Some companies also provide pre-measured water sachet for the ease of use. Otherwise, we need to mix the two components, water and powder. So the important barrier to the widespread use of MTA. It's not a very commonly used product by the clinician. Why? Because of its cost and difficulty in storage. So what is the mechanism of action of MTA? So the regeneration of new cementum or MTA is a unique phenomenon that has not been reported to occur with any other root end filling. So this is the only one material or the unique material which shows a new cementum formation. So this deposition of cementum hard tissue with MTA was also seen in dental pulps, apical tissue after this root canal filling. So this deposition of cementum may be due to the number of factors such as sealing ability, its biocompatibility, or alkaline pH on setting. So the setting reaction, what happens is on hydration, the calcium silicates in the powder undergoes hydrolysis when it gets mixed with water and produce calcium silicate hydrate and calcium hydroxide. So about 1/3 of hydration products is constituted by calcium hydroxide, which makes MTA highly alkaline. And it offers biologically active substrate for bone cells and it stimulates interleukins production. When it contacts with this pulp tissue or culture medium, produces deposition of these calcite crystals, and it was observed that there is rich extracellular network of fibronectin in close contact with these crystals. So this is definitely superior to all other root and filling materials such as amalgam, IRM, super ABA in factors such as leakage of methylene blue, Fusobacterium nucleatum and enterotoxin. All these can be prevented. And it is biocompatible as I mentioned earlier and induces osteogenesis and cementogenesis, that is a bone formation and cementum formation. So which makes it an ideal choice of root repair. So this is the best root end filling material. So various applications such as it can be used as a pulp capping agent, can be used for root resorption, for apexification, the furcation problem and the perforation repair, and also root end filling. So the advantages, it forms an immediate apical barrier over the conventional apexification treatment. So it can be achieved in a single appointment. That is the most important factor. It can be achieved in a single appointment. So MTA can be used as a one-step obturation material in an open apex because of this property. So the 70% of the failures in steady perforation repair were associated with extrusion of the repair material. So the material which we are using will definitely extrude to the periapical area, and most of the failures, that is 70% of the failures, are due to this problem. But when we use MTA, it does not have to be compacted as firmly as the other materials like amalgam to adapt adequately to the tooth surface. So it will not create that problem. Okay, so the setting ability of MTA is uninhibited by blood or water. So this is not getting extruded to the periapical area because it is uninhibited by blood or water. So most of the failure chances are gone. So the slow setting time of MTA is an advantage in that it reduces the amount of setting shrinkage, which may help explaining the MTA low micro leakage. And the common problem in performing endodontics in immature teeth with necrotic pulp and wide open apex is obtaining an adequate seal of the root canal system because the root end is not closed. So in that cases, this MTA will be an excellent product to create an apical plug so that it is sealing the apex, thus preventing the extrusion of filling material. And it has also got antibacterial effect and the low solubility and radio opaque, slightly more than that of dentine. But the main problem with this MTA is MTA dissolves in an acidic pH. So when it comes to contact with the oral tissues or oral cavity for an extended period of time, there are chances of dissolving. And MTA powder has to be mixed with sterile water, and we just cannot use with any anesthetic or sterile liquid. This is because the effects other liquids may have on MTA's physical, chemical and biological properties. So excess moisture has to be removed from the preparation or receptive defect site, because MTA becomes so soapy and difficult to condense, and it has got low compressive strength, so it cannot be placed in a functional areas. The next one is Biodentine. So Biodentine was developed by Septodon's research group as a new class of dental material which could conciliate high mechanical properties with excellent biocompatibility as well as a bioactive behavior. So the material is actually formulated using the MTA based cement technology, and the improvement of some properties of these types of cement, such as physical qualities and handling. So these two properties were lacking in our MTA. Okay, so the handling properties and the compressive strength. So those properties were improved in Biodentine. So this is a composition: tricalcium, dicalcium silicate, calcium carbonate and oxide, iron oxide, zirconium oxide. Then liquid calcium chloride, hydrosoluble polymer. Setting time is around 45 minutes. The shortest setting time was attributed due to the addition of calcium chloride in the mixing liquid. Compressive strength is higher is due to the low water cement ratio. So it has got many uses, such as it can be used for dentinal caries, perforations, resorptions, apical surgery, pulp exposure, pulpotomy and apexification. So the material is characterized by the release of calcium when in solution, and this tricalcium silicate based material also defined as a source of hydroxyapatite when they are contact with synthetic tissue fluid. So another area of use is when we have a repair of perforation, and this is very interesting. So there will be a push out bond strength, so we need to have a material with push out bond strength. So it is essential that a perforation repair material should have sufficient amount of push out bond strength with dentinal walls for the prevention of dislodgement from the repair site. So this has that good push out bond strength to act as a resorption reparative material. So biocompatibility, it is very low cytotoxic and it has got very good tissue acceptability. So it can be used for pulp capping, perforation repair or as a retrograde filling. So I mentioned in the beginning, same material can be used as a retrograde filling, then for a resorption purpose or for regenerative purpose. So when question was asked, you can include all of these. Now we have some newer materials. So newer materials, actually it should come before this. So the first one is ERRM, that is endosequence root repair material. So it is a putty and paste based material. It is available as ready to use pre-mixed bioceramic material recommended for perforation repair, apical surgery, apical plug and pulp capping. So this was asked once, that is a newer material in root filling group. So first one was ERRM. The next is a PRF, that is platelet rich fibrin. So these biomaterials are native or synthetic polymers that perform as scaffolds for tissue regeneration and hold very important role in the field of dentistry or drug delivery, cancer treatment, thrombotic diseases and cosmetic surgery. So this PRF is a very new material which can be used as to regenerate the lost dental tissues. So various bioactive materials are available in today's time, like MTA, bioactive glass and bioaggregate materials. So in regenerative endodontic therapy, an ideal autologous material for pulp dentine complex is our PRF, that is a platelet rich fibrin. This has got regenerative potential, unlike all these MTA and other materials. So it was first developed by Chokron in 2001. It has got growth factors like platelet derived growth factor and transforming growth factor beta. So it sees for at least 1 week and up to 28 days. So it keep on releasing till 28 days. So its application include root coverage, bone regeneration, treatment of endoperiolesion, sinus lift procedure, stabilizing the graft material in augmentation procedure, socket preservation, filling of cystic cavities, and in various medical fields. So it represents a revolutionary step in platelet gel therapeutic concept. So what is the advantage of platelet rich fibrin over platelet rich plasma? They are now biochemical handling of blood, simplified and cost effective. Use of bovine thrombin and anticoagulants are not required. Favorable healing due to slow polymerization, more efficient cell migration and proliferation. It has got supportive effect on immune system and it helps in hemostasis. So these are the advantages of PRF over PRP. So how do we prepare this PRF? So it's very simple. Collection of whole venous blood around 5 ml in each of the two sterile tubes without anticoagulant, and these tubes are placed in a centrifugal machine for 3000 rpm for 10 minutes, after which it settles into following 3 layers, that is the upper straw colored acellular plasma, then red color lower fraction containing RBCs, whereas the middle fraction containing the fibrin clot. So this is our area, fibrin clot, PRF. Now we have a newer material, that is endosequence BCRRM. So this RRM is nothing but root repair material. It's available in 2 specifically formulated consistencies, syringeable paste or condensable putty, and contains many of the same characteristics of BC sealer. It basically includes calcium silicate, calcium phosphate monobasic, zirconium oxide, tantalum oxide, filler and thickening agent, and its pH is greater than, so it's more of an alkaline nature. So it has got good favorable good handling properties, increased strength and shortened setting time makes this material highly resistant to washout and ideal for all root repair and pulp capping procedure. It is very highly biocompatible and osteogenic. It creates bone formation. The next one is iRoad BP Plus bioceramic putty. This is like a fully lab synthesized water based bioceramic cement. It is ready to use white hydraulic premixed formula. It is biocompatible and did not induce critical cytotoxic effect. So all you need to learn this, at least the name of the newer material, so that you get more content in writing if the question was asked the newer segment of root repair or newer materials in the root and filling section. So at least write the title and 1 or 2 bullet points. Next is a bioaggregate. It appears to be a modified or synthetic version of original MTA. It has got ceramic nanoparticles and deionized water. So this appeared to be biocompatible compared with WMTA on human pulp cell, PDL cells and MG63 cells. It contains calcium silicate hydrate, aluminum hydrate, calcium hydroxide, all these things, hydroxyapatite, bismuth oxide, tantalum oxide, calcium sulfate, and amorphous silicon oxide. And we have the novel root end filling material, NRC. So the novel resin based root end filling material, termed as newer resin cement or NRC, is a powder and liquid system. This liquid composed of this hydroxy ethyl methacrylate benzoyl peroxide, toluene and toluene sulfonate, and the powder is made up of calcium oxide, calcium silicate, and triphenyl bismuth carbonate. So this is a very newer one. So that was all about the root repair material. We covered many materials, the existing one, MTA, and the newer ones, and all these can be used as a root end filling material, then for the repair or for resorption repair, and as a regenerative material. Some materials has got regenerative potential, like this bioaggregate, this PRF, Biodentine, all these got this regenerative potential, whereas some are excellent in apical plugging like MTA, and commonly used or old ones, that is eugenol based. They have two different modification, that is super EBA and IRM, and amalgam, Gutta-percha, all those things with GAC and composite. Diaket is also there. So hope you understood this topic. It will be definitely asked for a short essay or a long essay, or MTA alone can be asked as a short note. So it's a very important topic. All these points would be sufficient to get you good marks in this question. So I'll come up with a new topic in Endodontics. Thank you.